Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to be beginning with our Prosthodontics series with the first lecture of occlusion schemes in complete denture patients. Dr. Kanan and Shah has put together a brand new lecture for us, so let's get on with it and continue with table of contents. First we'll introduce what occlusion really is, then we'll discuss a bunch of related terminologies. These will be extremely important, so make sure to get your notes and pens out, you guys. And then we'll continue with natural versus complete dentures and bilateral balanced occlusion. And now squint is a part of bilateral balanced occlusion, so it's a very important topic. Monoplane and lingualized occlusion will be next, and then we'll define what an ideal occlusion is, and then of course references. Just to kind of get our excitement jogged up, guys, this is an actual denture of Washington, the President of the United States of America. Yep, it's made out of ivory and wood. I would not want that in my mouth, you guys. I don't know how he pulled it off for so many years during his presidency. Anyways, let's start with the background. Now, I know this is not the actual lecture for TMJ anatomy, but it's very important to understand how it plays a role when it comes to, say, centric relation or centric occlusion or translation or hinge axis and so on and forth. That's why this anatomy is very important. However, we will discuss more of it in our second lecture of mandibular movements, so stay tuned for that one. Now, just to get started with this, we know it's condyle as well as the glenoid or mandibular fossa intermediated with the articular disc that runs the condyle along the articular eminence when it comes to the opening and closing movements, right? That's the basic. But what's really important is to understand centric relation. And that's where this area comes into play. The thinnest avascular portion of the articular disc that is at the slope of articular eminence where the condyle touches when it rotates. So that's just one reason why it's important to know the TMJ anatomy for today. Okay, otherwise there's capsule, there's joint cavity, both superior and inferior, and there's a lateral pterygoid muscle and retrodiscal. Like there's a lot going on here. But for this lecture, that review was enough. So, introduction to occlusion. What is occlusion? First of all, it's a static contact relationship of maxillary mandibular teeth. So it's teeth or analogs, which means acrylic teeth put into dentures at any given position. So we know it's static, which means has nothing to do with function. So what does really have to do with function? That's when articulation comes into play. It is a static and dynamic contact relationship between occlusal surfaces during function. And we'll take a look at that again during our second lecture of mandibular movements. Occlusal plane is the mediolateral and anterior posterior layer of contacts of over the incisal and the occlusal surfaces of teeth, such as the incisal edges and cuspal tips. So imagine laying a big piece of paper on top of the mandibular teeth. Whatever shape it takes, such as the ones in the line right here, as well as the anterior posterior, that grid right there, that is the occlusal plane. Now, why it's important is what we will talk about in the Hanau's squint. So wait up for that. Here is a representation of centric occlusion. What centric occlusion really means is when teeth are touching completely at centric relation. That's all it means. So, of course, we'll dig deeper into that. I'm just trying to get you guys warmed up to this topic by bringing you to the largest definition in prosthodontics. I know this is very hard to remember, and of course, in many exams we have to write the entire definition. But let's understand it for today. Centric relation is the maxillomandibular relationship. So it is a bone-to-bone relationship in condyles that articulate with the thinnest avascular portion of their respective discs. So for example, over here, this is the condyle, this is the disc, right? Articular disc. Now I'll show you what the thinnest avascular portion would look like. That is right here, the thinnest avascular portion. which makes it complex, which is complex means a combination of two things, in the anterior and superior position against the slopes of the articular eminence. Okay, so let's carry on with our explanation. This right here is the articular eminence's slope. Fair enough? Okay, now condyle touching the avascular thinnest portion of the disc at the anterior and superior slope of the articular eminence. Fair enough? That's clear so far? Perfect. This position is independent of tooth contact, which means when we talk about centric relation, it has to do with bone to bone, has nothing to do with teeth. Doesn't matter where teeth are. They could be occluding, they could be disoccluded, it doesn't matter. This position is discernible when mandible is directed superiorly and anteriorly, which means when the mandible is moved upwards and ahead, that's when it hits the articular eminence at the superior anterior complex. It is restricted actually by a purely rotation movement about the transverse horizontal axis. So what is transverse horizontal axis? Now if you look at our face, now this is going to be a terribly drawn skull, you guys, so bear with me here. Anyways, here's where the condyles would normally be, right? And this is the mandible. Transverse horizontal axis is the actual, imagine a rod that touches the two condyles together, and condyles will be able to rotate along that axis. This red line is transverse horizontal axis. So centric relation can only be measured when it is rotating, purely rotating, along the transverse horizontal axis. Fair enough. So that's the definition, explanation of centric relation. So now let's read it. Centric relation, the maxillomandibular relationship in which condyles articulate with the thinnest avascular portion of the respective discs, forming a complex in the anterior and superior position against the slopes of the articular eminence. This position is independent of tooth contact. This position is clinically discernible when the mandible is directed superiorly and anteriorly. It is restricted, purely rotation movement, no translation, about the transverse horizontal axis itself. And it is a bone-to-bone relationship. Fair enough? Can we picture centric relation with me, guys? Hopefully? Perfect. If not, please leave your comments down below and we'll clarify it without a doubt. So it is the most retruded position on the physiologic position of the mandible. It is the furthest back mandible will ever go. Doesn't matter, again, it doesn't matter if the teeth are touching or not. It doesn't matter. It has to do with everything in this red circle right here. It is independent of tooth contact. It is purely ligament guided relationship. So this could be a question in an exam. What type of a relationship is purely ligament guided? It would be centric relation. This position is repeatable and reproducible. That's why it's important, because every time that we need to put somebody's teeth or casts on articulator, we have to get the patient's record in centric relation. So that's why we call it CR records. Now, because it is transverse horizontal axis, centric relation becomes a horizontal relationship. Now, because we said horizontal with such emphasis, and very awkwardly of course, but nevertheless, if there's horizontal, there will be a vertical relationship. So keep that in mind, there will be a vertical relationship. Anyways, moving on. Eccentric relationship. It's any other relationship of the maxilla to the mandible other than CR. That could be protrusion, laterotrusion, mediotrusion, and so on forth. Okay, moving on to more terminologies. Terminal hinge axis. We just talked about it. It's a fixed axis upon which the condyles will rotate in centric relation without any translation movements. It's pure rotation. Up to 22 millimeters of jaw opening can be filled with rotation movements. Centric occlusion. Centric occlusion is self-explanatory. It is occlusion at CR. What the sentence says is more explanatory, however. It says occlusion of opposing teeth when the mandible is in centric relation. May or may not coincide with maximum intercuspation. This sentence is very important. I'll explain to you with this highlighted statement here. Just a minute. Centric occlusion is a tooth-to-tooth contact. It is when teeth are touching each other. It is during stationary occlusion at centric occlusion. Posterior teeth are at maximum intercuspation and the anteriors merely are apart. So for example, in this denture right here, it is seeming like this is a centric occlusion. The posterior teeth are in contact with their maxillary or mandibular counterpart, right? But at this time, the anterior teeth will be slightly apart. So try it. Try closing your mouth, touching the teeth as if you're biting, and holding it in a stationary position. Now pull your mandible back a little bit behind, and that's your centric relation. If you can't get that, try swallowing. If you swallow with your mouth closed and teeth touching, that makes your centric relation. At this position, you'll notice that your anterior teeth are slightly apart. And that's centric occlusion. Occlusion of teeth at centric relation. Next is maximum intercuspation. Maximum intercuspation is very vague, right? Because you're kind of mixing centric occlusion as well as just teeth touching at their maximum capacity. At which relation? Well, it doesn't really matter. If you think about it, it is just a complete interdigitation of cusps to opposing grooves and fossas. It has nothing to do with the condylar position. That's where it gets a little tricky to understand. See, maximum intercuspation just means complete interdigitation. Centric relation is the most posterior position of the condyles, and centric occlusion is the maximum intercuspation at centric relation. Does that make sense? Perfect. So, centric relation plus maximum intercuspation makes centric occlusion. Is that concept clear? Now let me explain what's in the brackets, guys. Centric relation is a little bit posterior to maximum intercuspation in people that have teeth, dentate patients. So for example, for us, if you chew down on your teeth to maximum intercuspation and then slide your mandible back a little bit, so that 2 millimeters of a glide backwards posteriorly is your centric relation because we're dentate. But in patients who are edentulous, who have no teeth, and when we're making complete dentures, we have to be able to make maximum intercuspation the same as centric relation. This is because they have no proprioception. They don't know when their teeth are touching to the point where they can create a separate centric relation. So that's what the brackets are saying. The centric relation is posterior to maximum intercuspation in people with teeth. Maximum intercuspation has to be the same as CR in edentulous patients. However, when you put CR and maximum intercuspation together, that's when you get centric occlusion. Hopefully this slide is very clear, you guys. And this is the transverse horizontal axis represented with a diagram from our references in the textbooks. It is pure rotation along an axis that connects a condyle to the other condyle. Fair enough? So that is axis upon which something rotates. But planes are something that we use to visualize something. For example, if you're looking at somebody from the side, like if you're looking at somebody's head from the side, this is you're looking at from the sagittal plane. You're cutting their body vertically sideways where the pink glider is. Whereas horizontal plane is looking at from the top. You're looking at it downwards. You're cutting them sideways, horizontally, and you're looking at them from the top. So your head would kind of look like this, whereas the nose would pop out like this, right? Eyes are here. That's horizontal plane. Frontal plane is you're looking at a person from the front. Happy face. And that's the frontal view of the planes. Just another addition to the terminologies. Moving on to more terminologies. Rest position. This entire page has to do with vertical relation, guys. Remember when we said with CR it was horizontal? Well, this is vertical relation. So rest position. What is rest? It's the physiologic postural position of the jaws. It's when all muscles supporting the jaw have become relaxed and the head is sitting upright. So try it. Close your mouth and let your jaw drop, but don't open your lips that wide. Don't open your jaw. Just let your teeth drop. And that's your rest position. How do you measure it? Well, vertical dimension at occlusion and vertical dimension at rest really help us. See, a vertical dimension measured from the tip of the nose to the tip of the chin at the time of maximum intercuspation or occlusion is the vertical or superior inferior maxillomandibular dimension at maximum intercuspation. Okay, now afterwards, let's drop our jaw a little bit and create vertical dimension at rest. And that is at rest, guys. So after this gentleman has clenched very hard in order to get VDO, that person has let go of his lower jaw, relaxed the muscles, and now we have VDR. Also measured from the tip of the nose to the tip of the chin. Now if you think about it, the VDO will always be less than the VDR. That's because this distance is longer when our jaws are relaxed and drop down versus when they're closer together. So in a sense, we have VDO, which is less than VDR. Fair enough. But how much less? And what's that difference called? Well, it's called freeway space. It is the voided space between the maxillary and mandibular occlusal surfaces at the rest, which is about 2 to 4 millimeters. So in other words, if you consider an average amount, the VDO will be less. So say for example, it measures to be 40 millimeters. But when you drop the jaw, this could become 43 millimeters. And that difference, 43 minus 40, is 3 millimeters. This becomes your freeway space. Average is 2 to 4 millimeters. Now in the construction of a complete denture, we measure the vertical dimension of occlusion and then we measure the centric relation. It's just a thumb rule that we follow. Vertical relations first and then horizontal. Vertical relation first and then horizontal. Once that is done, we articulate teeth on an articulator. Of course, we'll go through a lot of these in detail when we talk about articulators and teeth setting appointment in our future lectures. Alright, moving on to the next part where we deeply explain what freeway space is. The voided space between maxilla and mandibular occlusal surfaces at rest. VDO and VDR are always in constant fight. This is VDO, where teeth are touching. Now where teeth are apart due to the relaxed mandible, this is VDR. And the difference between the two is the freeway space. It's 2 to 4 millimeters. Now that also means that if VDO increases, the freeway space decreases. So for example, let's take the same numbers as we did earlier. 40 millimeters, 43 millimeters. Difference is 3 millimeters. Okay? If VDO increases, if we went up to 42, then that number now becomes 1, right? 43 minus 42. But if VDO decreases, then freeway space increases. So for example, if that 40 went down to 38, now the difference between these two numbers is 5. So the freeway space went up. Similarly, you're looking at VDR, that if VDR was to increase, the freeway space will increase as well. So think about it. If this turned into 45, but VDO was still 40, then it's 5 millimeters. It went up from being at 3, right? And then the opposite is also true. So that thumb rule really helps us when a question is asked, such as, what happens when the vertical dimension of occlusion is increased? Well, it's completely opposite of freeway space. VDO increases, freeway space decreases. But vertical dimension at rest, when that increases, freeway space increases. Now, I used to have a hard time remembering this concept, but for an exam perspective, how I remembered it was kind of silly. But I know we like silly to remember. Think of it this way. When you're free, you're resting a lot more. The more you rest, the more free you really are. The more free you are, the more rest you're going to take. So rest increases, freeway space increases. If you know this, everything else will fall into place. You know why? Because rest increases, freeway space increases. Rest decreases, freeway space decreases. If these are proportional to each other, then VDO and freeway space are inversely proportional. In other words, VDO increases, freeway space decreases. Is it easy to remember the rule now, guys? Awesome. Let's move on. We're moving on to the difference between natural teeth and denture teeth in dentition concepts, of course. Okay, very, very important slides, guys, so let's pay attention here. In natural teeth, the centric relation and maximum intercuspation may not coincide. There could be a 2 millimeter defect amongst the two numbers. It is activated by PDL proprioception that allows the mandible to move from centric relation to maximum intercuspation without damaging occlusal forces. See, basically what happens in natural teeth is our proprioception given to us by the PDL is extremely useful to move the mandible from maximum intercuspation to centric relation posteriorly. It's about 2 millimeters, just for the reference. That 2 millimeter of a difference is controlled by a concept known as PDL proprioception, the ability of the PDL to direct those minute senses of the muscles. However, in normal dentures, those interferences are overcome by PDL proprioception. We can take care of the differences. But when it comes to a complete denture, the CR and the MIP must coincide because of obvious lack of PDL. We don't have teeth, no PDL. So if there's a lack of PDL proprioception, if the mandible tries to move from CR to MIP, then the artificial teeth will face damaging forces because they won't know how to get from CR a little bit ahead to maximum intercuspation. Therefore, to avoid these denture base movements, the instability, we have to overcome those interferences by making centric relation the same as maximum intercuspation. So when we're making a CD, a complete denture, and when we're setting teeth in maximum intercuspation, we will set them at the pre-recorded centric relation. Remember, we do vertical dimensions, then we do horizontal dimension, which is centric relation, then we set teeth, which is in maximum intercuspation. That makes our complete denture complete. So when we set our teeth in maximum intercuspation, we already have a predetermined centric relation. That's where we will set those teeth to avoid any instabilities. Fair enough? Great. In natural dentition, bilateral balance is rarely achieved. This is because we can't have both our posteriors and anteriors touching together. Try it if we may. Try closing down your teeth at posteriors. You'll notice that the anteriors do not touch. But if you move your teeth ahead and protrude your mandible, have your anteriors touch, you'll notice that your posteriors will disocclude. So that is not bilateral balanced occlusion. It is actually called mutually protected occlusion. Our natural teeth are generally guiding us to mutually protected or canine guided. Another way to remember this canine guided is try and move your canine tip, your maxillary canine tip, to your mandibular canine tip. When you touch those two tips, you'll notice every other tooth in the entire oral cavity is disoccluded. Right? Well, that's canine guided. Or when anteriors are touching, posteriors are disoccluded, and vice versa. That is mutually protected. But again, we can't have that in complete dentures. Bilateral balanced occlusion is a must in complete denture patients because it helps the denture base stability and it prevents non-vertical forces, traumatic forces. So in complete dentures, all the teeth must touch together. That's the best case scenario. If that's not possible, then we can have what is known as a three-point contact. Three-point contact, so for example, if this is your lower jaw, you could have a contact in the anterior region at the canines and both the molars touching at maxilla and mandible at the same time. This is bilateral balanced occlusion. And this is important for creating complete dentures. We can't have a mutually protected. Think about it. If you have a denture in your mouth and you have a maxilla and a mandibular denture touching each other at the anteriors, can you imagine the posteriors touching each other? It will actually lift off, right? It will lift off the retromolar pads. Hence, it will cause denture instability. That's why we need balanced occlusion. And we will, of course, deeply talk about balanced occlusion in the coming slides. In natural dentition, we also have Christensen's phenomenon. That's what this is, the disocclusion of the posterior when the contact of the anterior happens. It's the protection mechanism of anteriors to posteriors as mutually protected. Complete dentures, all teeth are in contact at the same time to allow even distribution of occlusal forces over entire denture base. Now this is another reason to have a bilateral balanced occlusion. Think about it. Your normal teeth have PDL in them. PDL are really, really strong. For example, canines, the corner of the mouth, very strong. It can handle all the occlusion, weight, the mass, the force put on it. But can an acrylic tooth do that? That does not have any PDL fibers? Well, no. That's why we need to have even distribution of occlusal forces along the entire denture. That's why we need bilateral balanced occlusion. All right, so we're diving a little deeper into the bilateral balanced occlusion. But let's first talk about what the requirements are for a complete denture's occlusion. See, a sluice way or escape of food is needed. Sluice way just means how it's self-cleansing for teeth in the embrasure region to remove the food and not let it get stuck there. Because remember, plaque and calculus can absolutely build on artificial teeth as well. The other is shearing and cutting efficiency of masticatory surfaces. So we need to make sure that certain angles of the cusps, the inclinations, are good enough for cutting and shearing forces as well, because we're replacing natural teeth. And of course, bilateral balanced occlusion is a must. We've talked about that and we will continue to do so. We also need to make sure that there are no interferences during mandibular movements. This is our next lecture. And then there's a lever balance. It is the relation of the tooth to its denture base, tooth to denture base, where the teeth can be placed slightly lingually. So if this is your mandibular ridge, for example, your denture base is representing your alveolar ridge, right? And anatomically, well, you want to put your mandibular molars a little bit lingually. The reason being is because you want to let the food bolus not drive outwards, not stay on the ridge because it hurts the alveolar ridge, but actually a little lingual so that it kind of allows itself to chew better. But that's for posteriors because all the other teeth can be put directly on the alveolar ridge itself, the denture base itself. So that's liver balance. All equal contacts for all posterior teeth. All of these with the counterpart in maxilla, they have to be touching each other. And then comes the Thielman's formula, the Hanau's quint, that can be used to create balanced occlusion in other occlusal schemes. So, balanced occlusion, monoplane, as well as lingualized occlusion can be used by Thielman's formula. All right. This formula is Thielman's formula. also known as henhouse squint. What are the factors associated with this? So let's introduce a new formula amongst you guys. Condylar guidance, incisal guidance are in the numerator, the upper number. Occlusal plane, cuspal inclination, and compensating curves are in the denominator. Now, I know there's a lot of factors in there, but we'll take a look at them one by one. But for now, focus on one thing, you guys. Condylar guidance and incisal guidance are what's related among both maxilla and mandible together, right? They're maxillomandibular. So any relation that is associated with both the jaws is at the top. But occlusal plane, cuspal inclination, or compensating curve, they're all within the same arch. So this is either mandible or either maxilla, and they're at the bottom. So just remember that for now, guys. All right, just write these tips down on the side a little bit, you guys, and it'll help you put together the whole scenario at the end of the lecture. Classifying occlusal schemes. In complete dentures, there could be 3 types of occlusions: balanced occlusion, monoplane, lingualized. Balanced is when there's all teeth in contact at the same time to have even distribution among the ridge. However, monoplane occlusion is when, for example, the left here, right here, it shows occlusion in centric relation. See, both sides are touching each other. The right will show lateral excursion. Now, do you see on lateral excursion, this here is disoccluded? But all of that disocclusion is compensated by a flatter occlusal plane right here. A flatter occlusal plane. And that's monoplane occlusion. Right? Lingualized occlusion is, for example, on the left we have centric occlusion. Lingualized occlusion, centric occlusion. This is the lingual or palatal cusp of the maxillary teeth during centric occlusion, touching the mandibular fossas, but it's only the lingual, not the facial. Right? And this is an eccentric contact, that if the mandible is moving this way, only the lingual will touch, not the facial. And that's lingual occlusion. Why do we do that? Why do we need monoplane? Why do we need balanced? Let's find out. Balanced occlusion. In other words, bilateral balanced occlusion. The necessity for complete dentures. Maximum 3-point contact at excursion. In other words, excursion means left, right, up, down, front, back. Any other movement but centric relation is excursion. 1 anterior and 2 posterior contacts. That is bilateral balanced occlusion's minimum requirement. It is known as bilateral, simultaneous, anterior, posterior, occlusal contact in centric and eccentric positions. Of course, in centric relation, all the teeth will be touching at the same time. That's a given. However, in balanced occlusion, during eccentric positions, even then, we have all the teeth touching. And this is glossary of prosthodontics terminologies. Centric occlusion, remember, posterior teeth contact. That's centric occlusion. Lateral excursion is when the posterior teeth will contact on both the working side and the balancing side as well. Now, what does that mean? Well, it's this diagram right here. For example, the balanced occlusion has showing posterior tooth contact on the working side, which is here, and balancing side during lateral excursion, which is here. Now, what does that mean? We will obviously discuss this a lot in our 3rd lecture of Prosto about occlusal contacts, but I'll tell you what working side and balancing side means. Wherever the mandible moves, so in this case, it's moving in this direction. That makes this side right here working side. Whereas the balancing side, the other side that balances all the movement, right? Bilateral balanced occlusion, it has to balance the movement, the non-working side. Also known as balancing side is the other side. So in bilateral balanced occlusion, we have contact here and we have contact here. So in centric occlusion, of course, there is a contact everywhere. In lateral excursion, moving sideways to the left side, the posterior teeth contact on the working and on the balancing side as well. In canines, they contact on working side only, which means there's one contact, there's the other contact, and canines, which is the third contact, and that brings us back to the point where there is one anterior contact and two posterior contacts. That makes this a balanced occlusion. Beautiful. And that's lateral excursion. But during protrusion, both anterior and posterior teeth contact each other. So if, for example, if this diagram were to show mandibular teeth moving forward in protrusion, all of these contacts will still be maintained along with this tooth touching right here. So all teeth are in contact, but minimum 3-point contact. Hopefully the definition of bilateral balanced occlusion is a little bit more clear, right? For example, here, this is the condyle, moves down, posterior mandibular teeth start to go forward and downwards, and the incisor in protrusion touches each other. Balanced occlusion showing anterior posterior tooth contact during protrusion movement. Fair enough? That's the diagram. Now, remember when we were talking about the lever balance? Here's the little diagram to explain that concept as well. This is from our references as well. A, right here, is the bolus of food. It's something that we chew. It's candy, for example. On one side, it creates the gap on the opposite side. Because it's here, this area is void. There's a gap. Okay? That's part of the description. Now comes lever balance. It is essential when this happens. And of course, a resultant force that is affected right here. All of the forces are affected right here. It should be directed on the crest slightly lingual. See, we can't have, when there's a bolus of food, and imagine if you had all the force right here. You know what would happen? This denture would tip up and become unstable. So the denture stability is compromised. Therefore, we're going to remove this right here and create a little bit of a lingual concentration. So the teeth will be placed a little lingually. That way, this stays on the ridge and does not take off. That's what liver balance does. It balances the liver, right? Liver. Fair enough? Okay, guys. Here are some pictures to depict what we've been talking about. Balanced occlusion of artificial teeth in centric position in a patient of an experimental group. So this is from our research paper that we were considering for the references for this lecture. You'll notice that there's contacts here. There's contacts here in the anterior as well as in the posterior there. The canines are touching here, and that's centric position. Everything's touching. Minimum 3-point contact. Balanced occlusion contacts in propulsion of patients in the experimental group where the mandible moved forward and downward. And you'll notice that there's still contact in the posterior teeth, and then there's still contact in the anterior teeth. And that is 3-point contact minimum in protrusion. And then this is lateral direction. If the mandible moves this way, there will still be contacts down in there as well as here, and of course one contact in the canine that we discussed about earlier. That is your 3-point contact. And of course same thing on this side. Canines will be in contact, one posterior minimum there and one posterior minimum there, and that is your 3-point contact. Fair enough? That's bilateral balanced occlusion in all different motions. So now let's discuss what manipulates that. What influences balanced occlusion? Remember we talked about the maxillomandibular factors And all of three of these are within the same arch. So what are they? Let's define them before we dig into them. Condylar guidance, just to clarify, it is something that we cannot control, something that we cannot change. It is natural. What does that mean? Do you remember the first slide we talked about, where we had the condylar head in the glenoid fossa and the articular eminence had the slope? Well, this guidance is basically just a little angle that forms right here with a horizontal plane. Okay, let me draw that so much better. This is so bad. I'm so sorry, guys. I'll draw this again. This is our condyle. Okay, and then of course this is our glenoid fossa with the articular eminence. And we know that during any motion, the condyle will take this route, downward and forward. Fair enough? Okay. Now, imagine that that angle right here of its motion is associated with an axis. So this angle that is formed here, that's what we call as condylar guidance. Now, do you guys really think we have the capacity to artificially change this angle? We can't. It has to do with the glenoid fossa and the condyle itself. So it's natural. Something that is natural we cannot change. Then comes incisal guidance. Now, because of this motion, you could imagine that at the anterior end of the mandible, the teeth are very much influenced by the condylar guidance, right? In other words, if condylar guidance is increased, incisal guidance will be increased, right? That's why these two terminologies are in the same numerator. They're not opposite of one another. They're on the same side. Okay, so far that's clear in the overview part. And occlusal plane orientation. Now again, occlusal plane orientation is something we can't really change a lot. Imagine putting a piece of paper on your entire jaw and trying to manipulate its position. We can't, not as much as we'd like to. But if we wanted to change the occlusal plane, for the reason that we need to correct a mandibular deficiency, for example, then we would touch up with its friends and the denominator within the arch. We would change cuspal angles. We would also change compensating curves. So what are cuspal inclinations and compensating curves? Well, think about it. If your entire tooth looks like this, the cuspal angles, basically that angle, with the vertical axis of the tooth, or a horizontal axis of the plane, all of these angles right here can be changed. You could make it, for example, steeper. So you could have it steeper, and now your angles are much, much larger, right? Very steep angles. Or you could have it shallower with a flat angle, no inclinations at all. That will obviously change the occlusal plane, right? Oh, of course it will. Cuspal inclinations affect occlusal planes. Higher it goes, higher the occlusal plane gets, right? In other words, if you imagine, if your cusps are steep versus if your cusps are flat, cuspal inclination is low, cuspal inclination is high. Do you think, visually speaking, occlusal plane is higher here or here? Well, of course it's higher here. So these are both of the same family. Higher occlusal plane, higher cuspal inclination. Similarly, compensating curves are the same. Compensating curves are basically like this is your condyle, move in here is your mandible. See how this is 90 degrees? This is not a curve. We need a curve. So what does a natural condyle and mandible look like? It actually kind of looks like ramus coming down here and moving down. See now right here, this is a curve. Now imagine if this curve was a little bit flat. Occlusal plane dropped, right? So if the compensating curve drops, occlusal plane also drops. So all of these are interchangeable. These are the factors that determine how balanced occlusion is achieved, and it's known as Thielman's formula, or better known as Hanau's quint. Okay, so let's discuss the whole concept in detail. This is the balance, right? We just talked about this. This is the condylar guidance, the motion to which the condyle moves downwards and forwards, how that affects the incisal guidance, where these two are the incisal teeth, and the angle of its motion is formed with the horizontal plane, right? What is incisal guidance? It is when this plane intersecting the maxillary incisor vertically touches the horizontal plane right here. This angle right here is incisal guidance, and it is highly affected by condylar guidance. So incisal guidance, condylar guidance. And then we're moving on to the other factors in the denominator, which is cuspal inclinations, the horizontal plane associated with the angle of the cusp, right? There's the cusp. So this angle is your cuspal inclination. This right here is your occlusal plane. Occlusal plane is how your teeth are set. Remember that paper on your entire tooth surface, touching the incisal, cuspal, tips, all of it? How that is associated with horizontal plane. Fair enough? All of that is occlusal, or sorry, occlusal plane. And then comes your compensating curves. How they are affected. How steep they are, how narrow they are. So these are compensating curves. This is occlusal plane. Now, did you guys notice one thing very, very certain about these? All of these are associated with some sort of a horizontal plane, right? Horizontal plane, look at that, everywhere. So angles are associated with horizontal planes. Right here, that's a terrible horizontal plane. Okay, wow, that's even worse. Horizontal plane with any angle steeper, any angle shallower. And that's what we're going to play with until we find a balanced occlusion. Sometimes we could have a steeper curve or a steeper condylar axis. We can't change this, hence we shouldn't be changing a lot of this. Occlusal plane, not much changed. So now we're playing with two large factors. Cuspal inclinations, compensating curves. Fair enough? Okay. I know I'm trying to kind of bottleneck you guys slowly but surely, but let's find out what we can decipher for each factor. Okay. Factor number one, condylar guidance. There is no control over this factor. It's completely natural. A portion of the articulator in the upper posterior region, basically looks like this on the articulator, is what controls the condylar guidance. The controls of the movements of its mobile member. By mobile, we mean mandible, right? Maxilla is immobile, where mandible is mobile. So in an articulator, specifically, the mobile member is your mandible. Condylar guidance inclination is the angle that is formed by the condylar guide surface, right? Condylar guide surface, and a specific plane. And by specific plane, we mean horizontal plane. This right here. The average is 33 degrees plus or minus 2 degrees. This angle right here is 33 degrees. This guidance transverses the contours of glenoid fossa. So, in other words, the 33 degrees actually come from this. This is 33 degrees, allowing the condyle to flow down and forward at an angle of 33 degrees. It transverses the glenoid fossa. It is recorded by protrusive and lateral jaw relation. Now, I won't get much deep into this, but it's a new lecture for us, so we'll take a look at that in the future lectures. However, the only way to measure this is to measure the protrusive movements, right? So logically speaking, to measure this angle, we need the condyle to move forward, the mandible to move forward. Fair enough? protrusive record. As a rule of thumb, a shallow condylar guidance means that less posterior teeth separation will occur during protrusion. So imagine if you have a condylar guidance that is not very steep, it's not going like that, right? Where if you move it forward, the anterior teeth will touch and all the posterior teeth will disocclude, right? But instead, you have something that is very shallow. It's moving like that. Your condyle path is moving like that instead of moving like that, right? Instead of that, it's moving very shallow like this. Then your posterior teeth will not have much chance of separating from one another when it comes to anterior teeth touching. So a shallow condylar guidance angle is less posterior teeth separation during protrusion. So how do you fix this? Because that's a problem, right? It is solved by arranging the teeth with shorter cusps, right? So if, for example, if this happens, then what if we just did this? All of a sudden, this area is now greater during separation. Because we cannot change condylar guidance angle, we have to change other factors from the Hanau squint, and that is cuspal inclination. We use shallower cusp. Is that concept better? Perfect. Steep condylar angle. More separation. We just talked about how that happens in the posterior teeth. How do you solve it? Well, you make the compensating curves even steeper. So in terms of diagrams, if your anterior teeth are touching, but because of those touching, your posterior teeth are wide apart because your condylar guidance is so steep, then what do? Well, all you have to do is make your compensating curve, which is, say, curve of speed that looks like this, a little steeper. Instead of it going like that, we will make it steeper, right? If we did make it steeper, then this tooth right here will move up automatically, and this tooth right here will move lower automatically. So to balance that, we have to touch compensating curves. So in other words, if you remember, to prevent any issues from occurring here, we have to touch this and we have to touch this. Remember the blue circles that we touched? That what do we change? We change cuspal inclinations. We change compensating curves to help balance the natural condylar guidance. Fair enough, guys? So far, so good? Great. This is what it looks like in diagrams that we just discussed. This is a shallow one. This is steep condylar guidance. See how the glenoid fossa is very shallow? This is a very steep glenoid fossa, very steep glenoid fossa. In this case, what happens? It shows that there is a lesser difference between the separation of the posterior teeth. Whereas in steeper, there is a greater separation between posterior teeth. Greater. Right? This is less separation. If 45 degrees is your condylar guidance, then your incisal guidance is going to be very close. It may not be exactly the same, but it will be very similar. Okay? Remember, horizontal, horizontal. This is another version of shallow with less separation, steep with more separation. It's just a rule of thumb that we need to remember. Steep condylar guidance requires teeth with longer cusps and deeper fossa to achieve balanced occlusion, right? We need to change the two factors that we have. We have cuspal inclinations and we have compensation curves. That's what we can change. If there is a shallower one, then we need flatter cuspal inclinations. If there is a steeper one, then we need a more increased cuspal inclination. Fair enough? Okay, guys. Here's another picture of what it looks like. This is a steeper, right? This eminence, focus on this area here, guys. This is steep, this is shallow. Okay, perfect. Okay, second factor, guys, incisal guidance. Now, unfortunately, this is something that we can control. Remember, we had condylar guidance versus incisal guidance. They're very, very similar. And then we had our three factors in the denominator below, right? Okay, this we already talked about. Now we're on to this. It is preferred to be minimized to decrease non-vertical forces of occlusion. Fair enough. What that means is if, for example, if we went back to the diagram here, this is your incisal guidance, right? This is a very, very steep angle, 45 degrees angle. If the incisor was kind of like here, then this angle would be much larger. Do we want that? Do we want a flared out incisor? Well, the answer is no. We don't want a increased incisal guidance. We want it to remain minimized. See, it is guided by the incisal contacts of the anterior teeth when the mandible moves forward. During protrusion, the mandible moves forward and downwards, right? That motion is represented anteriorly by incisal guidance. Of course, posteriorly, it is by condylar guidance. The incisal guide angle is the angle formed between a horizontal plane of occlusion and the line drawn sagittally between the incisal edges of the maxillary and the mandibular central teeth at maximum intercuspation. The average angle is 10 to 12 degrees. Okay, so horizontal, and then your maxillary incisor kicks in right here. And of course your mandibular incisor is touching here. So we got the horizontal plane, we got the two incisors. Imagine a sagittal line. So if, for example, if there's a line being drawn sagittally between the two incisors and their tips, this is your incisal guidance. Okay, we'll take a look at a picture in just a second, guys. It is recorded during try-in procedures. Incisal guidance, if it is too steep, basically, if your incisor, the maxillary incisor, is set like vertical, and of course your mandibular incisor is like this. This is too steep, right? Too steep. That's the angle. Then it is detrimental to denture stability, right? If, for example, that happens, then can you imagine for a second that this maxillary tooth and the mandibular tooth touching each other, giving each other forces right here, will lift the denture bases in the posterior region? Well, that's the denture stability part, right? If the incisal guidance is too steep, then the denture stability is compromised. It will need steeper cusps. It will need steeper occlusal plane. It will need a steeper compensating curve to balance the occlusion. Remember that the three factors that were in the bottom right here, sorry, so this is condylar guidance and incisal guidance. The three right here, they were very similar to one another. If one increases, the other increases. If the one decreases, the other decreases, right? So if incisal guidance is too steep, then we need a steeper cusp. We need steeper occlusal plane. We need steeper compensating curves. Of course, we'll discuss ahead. A steep incisal guidance will produce greater separation in the posterior teeth. Therefore, it is desired to have it minimized and flatter, almost zero if possible. Now, as a rule, it should be less than condylar guidance, so that the balance between the posterior separation and anterior contact is maintained well. Remember, in bilateral balanced occlusion, we don't want Christensen's phenomena. Christensen's phenomena, what was it, guys? It was when anteriors touch each other, posteriors are separated, and vice versa. That's Christensen's, but we don't want that. We want posteriors in contact and anteriors in contact. So we want everything shallow. We want all of it shallow. We want the incisal guidance as shallow as possible, not steep. We want the compensating curves as shallow as possible. We want the compensation or the occlusal plane shallow as much as possible, right? That's the goal. So let's take a look at this diagram. The vertical overlap and horizontal overlap. We've all known about this. This is the overbite. And then this is the overjet, right? This determines, this C right here is the sagittal line with horizontal plane. So essentially this or this angle is your incisal guidance. And we want it. It is desirable. Guys, write this down, guys. It's desirable to have it shallow, especially less than condylar guidance. And what was condylar guidance? 33 degrees at an average. Here's an example of what we're trying to explain. If a steep vertical overlap exists, it is required for aesthetics, then a corresponding increase in horizontal overlap is also necessary. It will help decrease the incisal guidance angle. So if your teeth are being set this steep, then we need a greater distance horizontally, which means we need a steeper curve. We need steeper compensating curve. Steeper incisal guidance compensated by steeper curve. Fair enough? Perfect. Okay, third factor, occlusal plane. Now, the average plane is established by biting surfaces of the teeth. Remember the paper on teeth example. Incisal edges and cuspal tips, dictated by functional movement requirements of mastication. Everyone chews differently, right? How you chew forms how your occlusal plane should be. For example, anteriorly, it is determined by the height of the lower canines, coinciding with the commissure. So if these are your lips, and the corners of your lips are known as commissures, then your canines that are lying underneath here, inside, will be lined up exactly right here by the height of canine. Fun fact, eh? Very important to remember though, that the canines, mandibular canines, are exactly at the corner commissure, and that's how the anterior occlusal plane is determined. But posteriorly, it's the height of the retromolar pad. So if you're looking at it like this, the retromolar pad is somewhere around here. This is your third molar, second molar, first molar, premolar, canine, incisor, incisor. Okay? I know it looks like a skyscraper, but bear with me here. Any tissue behind here is retromolar pad, and that determines the occlusal plane posteriorly. Anteriorly, it's the canines meeting at the commissure of the lips. Fair enough? It reminds us of the curve of speed, doesn't it? Think about it. Isn't this kind of like a curve of speed? It is. Occlusal plane inclination should be limited to no more than 10 degrees. So, horizontal axis again, and occlusal plane starts here and kind of goes up at the retromolar pads. And this right here shouldn't be more than 10 degrees. The angle of occlusal plane is always determined by the plane of occlusion meeting with the ala tragus line. So for example, what's tragus? Tragus is that portion of our ear right here. This is our external auditory meatus. This is our tragus, that little hard cartilage. And of course our nose is right here. We have ala down here on the side. So ala tragus line. This is tragus, this is ala. And occlusal plane is generally like this. Right? That's our teeth, that's how they're set. Because over here, you're looking at your condyles, mandible, moving up. Now that right here, that angle with this line, this is 10 degrees. So it can be changed. Occlusal plane can be changed. Not a lot, but it can be changed by tilting the molar teeth. If the molars are tilted mesially, then a steeper curve is anticipated. If the molars are turned distally, then a flatter curve is anticipated. What does that mean? Well, think about it. Right now, the molars are set like this. Okay? What if I were to change the molar and tilt them mesially? Wouldn't this line turn into this, and that angle goes up to 20 degrees? What if I were to turn this molar into a distally tilted molar? Wouldn't this kind of get flatter, making this a 5-degree angle? Well, that's exactly what this is. If molar teeth are tilted mesially, that way, then it's a steeper curve. If it's distally, that way, then it's a flatter curve. Fair enough? Awesome. So here's the angle. Occlusal plane, this is the occlusal plane, right? Horizontally speaking, this way. Anteriorly speaking, this way. The piece of paper that we were talking about, this is the occlusal plane. And remember, ala tragus line, the ear is right here, tragus is here, ala of the nose right here. When those two touch together, makes the ala tragus line. So, a plane of occlusion should never be tilted more than 10 degrees because it creates a lot of differences in the disocclusion, and we don't want disocclusion, guys. The larger the occlusal plane angle, the more separation there will be, and we don't want that. This should be 10 degrees, always. Occlusal plane and ala tragus line. Number 4, compensating curves. Curve of Spee is the anterior-posterior curve. We've already kind of touched on this today. It follows the occlusal plane. Mandibular occlusal plane is traced using curve of Spee. The tip of the canine to the buccal cusp tips of the posteriors. Canine to the buccal cusp tips of the posteriors. Anterior border of the retromolar pad. Anterior border of the retromolar pad. Up the ramus. Up the ramus. If it is steep, we can anticipate class 2. If it is flat, it could be class 1 or class 3. How so? Well, think about it. This is your maxilla. Okay, this is your maxilla with your incisors falling down like this. Okay, now let's take a look at a curve of Spee that looks like this. A regular curve of Spee. Okay, this is class 1. But if, for example, I were to make this steeper, so it would look like steeper. Do you notice how the mandible now looks like it's gone back a little? If, for example, this became steeper, the mandible will open up a little bit, and all of a sudden the curve will look like that. Right? That's class 2, where the maxilla is dropped down right here. Okay, it's class 2 if it's steep. So if, for example, this is class 1, and if I were to open up the mandible, drop it a little bit, and make the curve of Spee steeper, then we move the mandible back from here to here. What happens when you move the mandible back? You get class 2. And the opposite is true. To make flat, it'll turn into class 3 or class 1. That's just a rule of thumb. You could write that down in your notes, guys. It helps obtain protrusive balance of the denture. The steepness is dependent on the incisal and condylar guidances. Remember, our job is to compensate each other's factors. So, if, for example, the incisal guidance right here, where the maxillary tooth would be, is very steep, then we need to compensate it by making the curve of SPE a little bit more shallow. We need to create a little shallower curve of SPE, right? So steepness is dependent on incisal and condylar guidances. The aim for bilateral balanced occlusion is shallow curve. Our goal is to make a shallow curve so that the posterior teeth will meet when the anterior teeth are meeting. Okay, this is the curve of Wilson. Curve of Wilson is a mediolateral curve. It's this way, mediolateral, touching the buccal and the lingual cusp tips of opposing quadrants, right here. Buccal, lingual, lingual, buccal. Buccal, lingual, lingual, buccal. It directs the lingual placement of the posterior teeth to help with masticatory functions and preventing non-vertical forces that may damage the denture. In other words, it helps with lever balance, the lever balance. And so this is our ridge right here, and it helps set our teeth a little more lingually, to help with denture stability and prevent non-vertical forces from damaging the denture. It is used to arrange posterior teeth during teeth setting step. It helps obtain a lateral balance of the denture known as the lever balance. That's curve of Wilson. And last curve is curve of Monsoon. It is the combination of SPE and Wilson, a sphere that forms with the concave curve of the mandibular arch, which is the curve of SPE right here, and the convex arch of the maxillary arch clubbed with the same on the Wilson. So this is your mediolateral, right? Now imagine all of these being connected in a pyramid where you take the same thing and you turn it around in the maxilla. Fair enough? Can we imagine that? It goes up here and it turns. So if, for example, this is your Wilson and your Monsoon curve, your SPE and your Wilson curve mixed together. Together it forms Monsoon when it turns into a sphere. It's taken into account at glabella at the center point. So this is your center point. The radius is 4 inches and diameter is 8 inches. So in other words, if I were to explain this better for you guys, if this is our skull, where's glabella? Right here. Where's our mandible? Right here. So what would the curve look like? The curve of SPE would be anteroposterior. The curve of Wilson would be mediolateral. Now imagine this entire circle going around like this, where the center is glabella and the radius is 4 inches on each side. Okay, this is curve of Monsoon. Combination of SPE and Wilson. Reverse curve or anti-monsoon curve is the convex upward curve used to arrange the first premolars. The first premolars are actually arranged a little bit this way. Remember when we talked about arranging the teeth in the lever balance, we mentioned that was for molars. Any other teeth, they don't follow that. Okay, so reverse curve is the set of premolars, first premolars. And last but not the least, the cuspal inclination, the factor. It is the angle formed by the natural slope of the cusp with the cuspal plane. What does that mean? Well, this is your natural cusp, right? This is your natural angle of the cusp. And what's the cuspal plane? It's this, the horizontal. That's where the cusps lie. The cusps are sitting right here. That's the cuspal plane. So that, in other words, that angle right there is your cuspal inclination. It is measured mesiodistally and buccolingually. And we'll look at the diagrams in a second here. The changes in the cuspal angles will affect the occlusal plane and the compensating curves, all the denominators in the equation. Remember, guys? Well, the closer the tooth is located to the incisal guidance or condylar guidance, the more influence that particular guidance has on the cuspal angle. Molars' cuspal angles should range from 20, 30, or 33 degrees. 20, 30, or 33 degrees of cuspal angles. It is the same for condylar guidance. It's very influenced by them, because if we want condyles to move this way properly, we want a smooth motion through the cusps. We can't have interferences hindering one another when we're moving forward, right? Okay. Ideally speaking, it is preferred to have a reduced cusp angle to help a better horizontal in balanced occlusion. So, just like the incisal guidance, just like the compensatory curves, just like the occlusal plane, the cuspal inclinations should also be shallow. Because when we're moving in a forward and a downward movement, or a left to a right movement, we want decreased horizontal forces affecting our denture base to help with balanced occlusion. Okay, let's take a look at the diagram so it's better understood that way. 20 degrees, 30 degrees, 10 degrees. Remember, incisal guidance should be less than condylar guidance. This is natural. We cannot change this factor, but in order to have the mandible move smoothly like this, we should have a shallower cuspal angle and a shallower incisal guidance. All of them have to do with the horizontal plane. Perfect? Awesome. What's the advantage and disadvantage of the whole bilateral balanced occlusion? The advantage is that it maintains denture base stability. Remember, 3-point contact in complete dentures. It's for better aesthetics of complete denture patients. It harmonizes with muscles of mastication. It helps them. It minimizes the tipping of complete dentures. That is a very important sentence, so red dotted, guys. But the disadvantage of bilateral balanced occlusion is the cuspal inclinations provide greater lateral forces. So, in other words, if this angle right here was larger, if the cusps were steeper, then imagine moving the mandible forward or sideways. It would be hard, it would be difficult to move the mandible smoothly. In other words, there would be greater lateral forces. So even in mediolateral cusp angles, they should be reduced extremely greatly. So we want to reduce cuspal inclinations. And of course, bilateral balanced occlusion is technique and time sensitive. Now see, the reason why a decreased cuspal inclination is bad and it's a disadvantage is because it prevents you from masticating properly. It doesn't allow you to chew or shear or cut an apple, right? Chew an apple. But it's really, really important so that horizontal forces are reduced and tipping of the CD is minimized. And that's why we call it balance, right? You take one, you give the other. You give one, you take the other. Now moving on to the monoplane occlusion summary. See, before you even read anything, you notice how the plane of all of these cusps are so flat? They're monoplane. The posterior teeth have a 0 cuspal height at masticatory surfaces. How easy is that to set? Not even technical, sensitive. Non-anatomical teeth are used. Teeth with no cuspal inclinations. It eliminates the cuspal heights that leads to much decreased lateral forces on the denture basis. The anterior teeth with 0 overbite, 0 overlap. But then there is a 2 millimeter horizontal overlap, which is overjet. How perfect is that? So on top of that, the balancing ramps can be used with monoplane occlusions to achieve balanced occlusion. See, now we're talking a little bit alien here, but let me explain this better. We've talked about using non-anatomic teeth with zero inclinations right here. Okay, fair enough. But because of that, there will be a slight imbalance in the horizontal overlap, right? Balancing ramps can be used with monoplane occlusion to achieve a balanced occlusion while doing eccentric movements such as protrusion. See, if we were to move these teeth forward, right, at that time, something like this would happen. Something like in the lateral excursion, how there is a difference in the contact here. These teeth are not touching. When the teeth are moving, yes, there's a contact here, there's a contact here, but no contact on the balancing side, only on the working side. In centric relation, yes, monoplane contacts here and here. But in movement, in function, the balancing side doesn't have contact. So we will use something known as balancing ramps to compensate for that. And what are balancing ramps? It's this right here. This is a balancing ramp in monoplane occlusion only. So monoplane occlusion, balancing ramp. Okay. See, a reduced number of posterior teeth is also another way where you can reduce posterior teeth and add a balancing ramp to the monoplane to achieve a balanced occlusion, where even in a protrusion, you'll kind of feel like even with no cuspal height, there's still a touching of the denture base in the back, right? So in terms of imagination, if the mandible was moved forward and the incisal tips are touching, a flat cusp shouldn't even be touching one another, right? Absolutely. Well, to compensate for that, our ramps will help touch, and that is our 3-point contact. And the other side, on the other right side of the denture, the same point of the balancing ramp, there's 2 points. So for example, if you're looking at from the top, balancing ramp, disoccluded molars, touching anterior. So contact 1, contact 2, contact 3. In monoplane. Perfect. Advantage. Monoplane, easy to arrange. When centric relation is difficult to achieve, go monoplane. Just go flat cusp. When there is a skeletal malocclusion and it's really difficult to attain a centric relation, you go monoplane. Can be used for patients with lack of muscle coordination. Remember, we need cuspal height to chew better. People who can chew better generally have better muscle coordination. But if a patient has lack of muscle coordination, then we can't give them steep cusps. They're going to have a hard time. That's when we give monoplane occlusion. When there is a residual ridge resorption, the residual ridge resorption. And of course, we'll make a separate lecture on it. But when there is a flatter ridge, then we need a flatter cusp, right? Disadvantage. It's not aesthetic. The non-anatomic teeth don't look good, they look flat. There's a decrease in mastication efficiency due to reduced posterior teeth and quantity as well, right? And especially when they're flat. Our goal is to prevent this entire curve of spee to kind of drop down like this. And to do that, all we got to do is get a flatter cusp instead of a steeper cusp, right? If the condyle guidance is really, really steep, then the denture becomes unstable, since the only compensation of the steep condylar guidance is a steep occlusal plane and cuspal angles. So what is that sentence trying to say? Is, for example, if your glenoid fossa is like this, where the condyle is like this, there is a very, very steep condylar guidance. In that case, a monoplane occlusion is used, because the disadvantage is that even with steep, you're looking at steep occlusal plane and steep cuspal angles, but monoplane prevents us from using steep cuspal angles, right? So it contradicts each other. If, for example, a condylar guidance is something we cannot change, if there is a steep condylar guidance, then having a monoplane occlusion will be a disadvantage, because in steep condylar guidance we need higher cusp, and in that case monoplane occlusion is contradictory. Okay, lingualized occlusion, the other one of the two neighboring occlusal schemes of bilateral balanced occlusion. Lingualized, before we go ahead, see the difference here? It's the lingual tips touching the mandibular. The lingual tips of the maxillary, the cusps, touching the mandibular fossas. Lingualized occlusion is the articulation of maxillary lingual cusp with the mandibular occlusal surface in centric position. The combination of balanced and monoplane occlusion, anatomic teeth, are used in maxillary teeth arrangement. So what does that mean? It means that there is a anatomic tooth with proper cusp, right? That's the balanced occlusion, with a monoplane occlusion with mandibular flatter cusps used. So anatomic teeth in the maxillary teeth, non-anatomic teeth in the mandibular teeth are used. Unlike balanced occlusion, however, lingualized allows only the palatal cusp tips to touch the mandibular teeth in both centric and eccentric relations. Hanau's quint can be used to achieve greater masticatory efficiency. So our formula, Tillman's formula, can be used to manipulate certain factors to get a better masticatory efficiency. But a new update is that the Meyerson's lingualized integration is become a concept where the manufacturers are producing molds for denture arrangements. So lingualized occlusion is taking popularity, where they now have molds of this denture arrangement. So just something that's very intriguing. Meyerson lingualized integration. Coming up in dentistry, guys. So for picture's sake, here it is. There's a lingual contact in centric occlusion, centric relation, maximum intercuspation, right? Whereas even when it is moving, there is a lingual contact and a lingual contact only. Remember in monoplane how there was a disocclusion on the balancing side and we used the ramps to compensate for it? Well, fortunately, lingualized occlusion takes it a notch ahead and helps us because we don't need balancing ramps. The palatal cusp tips are touching the mandibular occlusal surface, giving us a balanced occlusion. And that's why we had said that there is a combination of balanced and monoplane occlusion. What's the advantage? It's more natural appearing for the upper premolars, of course, because there's a cusp, right? Better at mastication than monoplane, but less than balanced occlusion. Balanced occlusion is still better. Elimination of lateral interferences because it's only the palatal cusp touching. The bilateral balance is possible using manipulation of the Hanau's quint, and it is best used if balanced occlusion cannot be achieved. But aesthetic is still a requirement, and the muscle coordination of the patient is adequate. That's the indication. Disadvantage is the difficulty of teeth arrangement in higher than monoplane because it's lingual on both sides, right? It's hard to set the teeth. It's less efficient as compared to balanced occlusion. Now, statistically speaking, yes, but do patients like it? Yes, absolutely. It's not scientifically backed by improving denture stability. So bilateral balanced occlusion is always going to be gold standard, but for denture stability, lingualized occlusion may not be a better version. Bilateral balanced occlusion is still gold standard. Cannot be used for flat ridges. We have to use monoplane, such as severe residual ridge resorption. Cannot be used for lack of muscle coordination, and we discussed that point. So this is a summary slide for the whole chapter that we just talked about. So you can feel free to pause here and use this from our references to take a look at it. Now, what I point out from this during this lecture is this sentence here. Even a minimum of 3-point contact, one anterior and two posteriorly on either side, may provide some balance in eccentric relation to enhance denture stability. This is the point that's a takeaway point for you for bilateral balanced occlusions concept. Perfect? Okay, so our resources are these two textbooks and this article here. The links will be posted in the description box below. I know this lecture may have been a little bit dry, but thank you for staying with us, and please continue to watch our lectures as we like being funny as well sometimes. And this is class 1, class 2, and class 3. Which breed do you like the most? Okay, terrible joke at the end of the class. I know, you guys are headed out. Have a good day, and thank you for watching. Please subscribe and like, and please share the Tooth Factory with other dental students and dentists across the globe. Thank you for helping us spread happiness, and thank you for the 6,000 plus subscribers. You guys are awesome for your support, and we love you. Thank you very much.